We are going live and I will start recording. Where is the recording? God.
It's downstairs.
Yeah, 20 people, 32 people, 36, 40.
I can see it.
Yeah, 50, 54.
Oh, he's recording. Good.
Yeah. 68 people. It just, wow.
It's increasing. That's excellent.
So somebody would start to say something in the chat.
Yeah, in a few
100.
moments.
Say hi, everybody.
Questions and answers and chat. Where is my chat?
Oh, Saleh bin Saleh. So it's good, as you can see, Paolo. It means people is really connecting from everywhere. If you, I don't know if you look about everybody attending. It's from Fabio Castiglione, just now in.
There is even a guy from London, Fabio.
Yes, those Italians from London.
Carlo, everyone hear you.
Yeah, I know, but I'm happy about that.
Yeah.
And so Fabio and you know, everybody from really everywhere in the world. That's very nice.
Colombia, great.
Yeah, Colombia as well. Turkey, Poland, Istanbul, India, Greece,
Africa.
South Africa.
It's amazing. Uruguay. Wow, Uruguay. Oh. I've been last year for a while. Fantastic. Luca from Rome. So
Indonesia.
there are some Italians, Paolo.
Sorry?
Brazil, Pakistan.
Brazil, Pakistan, it's incredible. Indonesia, amazing.
Colombia again.
Czech Republic, Brno.
Iran, great.
Yeah. How many people are still in? 135, it's incredible.
135.
Egypt, Amr, hi Amr. Holland. Israel.
User want to say something? I will give him the possibility to talk. User. Good evening,
yes.
User.
Hi, guys.
Do you want to say something?
I'm very glad to see this area, which is very good, and I hope it will be successful.
Thank you very much, User. It certainly will be. Paolo is rehearsing all day, so he will do it very well, I'm sure. And we are here to support him to all these ends from distance.
I understand him very hardly.
Thank you.
Thank you.
Fabio Castiglione.
Paolo, very smart. Okay, Fabio. Let's say something to Fabio. Come on, Kobe. Put Fabio in contact with us.
You need to raise his hand, otherwise I can not do nothing.
Okay. Hey, Ariel is there.
Ariel is also there.
Brazil.
Hi, Ariel.
I will give him the ability to say something. Ariel, do you want to say something?
Yes.
Hi, Ariel.
Oh, how are you doing?
Hi, Ariel.
Ariel.
I'm inside the ICU of a COVID ICU here in Brazil, and I'm having the opportunity of watching this webinar. I've sent this webinar to all my friends here, all the urologists. We are very happy to have this from the ESSM.
Thank you, Ariel.
Thank you very much.
Good to see you.
Thank you.
India.
Okay, wow. I will start we're going to start, okay?
Yeah,
100. Yeah, for sure.
Okay. Good evening, everyone. I hope that you can hear me. It's our pleasure to have the second webinar from the series of the ESSM statement. And this evening, we have the honor to have Paolo Capogrosso from Milan, Italy, He is the chair of the committee who conduct the systemic analysis to conduct our statement. And I'm very pleased that he is here with us. But before we start, I would like to give the opportunity to our president, Carlo Bertocci, to welcome you all.
Thank you, Kobe. It's really also my great pleasure to speak to all of you. I think this webinar series is a very good opportunity to spend some time together. I know this year will be very unlikely for physically moments to get together, but at least we try to make some alternatives. And I think this webinar are very interesting, not only for the contents, but also because we have a chance to speak with each other and to make questions and to be updated about some very interesting topics. If I may, I just would like to give you a couple of information about our educational activities, and you are leaving now one of them, that is the webinar. I don't know if Daniela can move on the next slide, but first of all, this is the two persons that I'm very proud to recognize that they've find out this very good solution of the webinar. And so both Kobe and Giovanni, they really build up this very interesting way to do some educational together. So thank you very much to both of them. And next, it will be basically to remind you what is our main activities in terms of education. And we are ready to update our sexual medicine and clinical sexology Bibles. You know that we are very proud of having done these two very, very well done books, one on sexual medicine, the other one on clinical sexology. So we are planning next year really to start this year, but to finish next year, the update of both of these. And so I think that maybe in the next year we will be able to give you these update books. And we are already with the textbook on surgery. This is ready. And so this is available from this year. And we hope to give you in the next ESSM meeting. But this is very important because it will be part of our Surgical Academy. So if we can move on the next slides, the Surgical Academy, I think, could be really our new big activity next year. You know very well about our School of Sexual Medicine, and now we give another important step in our educational. This is more focus on surgery, and this will be has been designed to have a full education, not only on theoretical part of the surgery, but mainly in the practice. And so we will have training on 3D models, and then also training as a fellowship in excellent centers all around Europe. And so we are sure that we can start in 2021 if COVID will run away from our countries. And so this will be really a very good opportunity next year for everybody who's interested for surgery. And the videos, the ESSM videos, you know that we already offer these very well done videos on erectile dysfunction, but we are also preparing, and we are ready to start also with some other videos that will be not only on erectile dysfunction, but will be also on surgery and other topics. So this will come very soon in our web, and so you will be aware, and you can take an opportunity really to see all of these nice videos. So basically, this is everything we can offer this year, unfortunately, so far, and I hope that we will have a chance to see each other in a different way, but I don't want to take any more time because the main topic will be to listen to Paolo, that is the star of the day. So thank you very much, and I hope to see all of you soon.
Thank you very much, Carlo, and I will give the opportunity to our scientific chair, Giovanni Corona, to say a few words.
Thanks, Kobe. First of all, I think that seeing the success that this webinar series have, the first one, the great success, and seeing how many participants are connected, almost more than 170 now. This means that again ESSM got a great success, but this idea was started almost 3 years ago by me and Kobe in afternoon during Oxford School, then fully supported by the ESSM EC meeting, and then by Carlo. But if we are able to reach such a great success, I think that we need to acknowledge all the members and especially all the sub-chairs of the scientific committee, and particularly thanks to Paolo. This is the statement on Shockwave was the first statement that we published, that we finalized, and now we have the possibility to share with you the results of this fantastic work. So I'm really proud on this team, and particularly really proud on having Paolo in the scientific committee. Again, we are probably next year we are going to promote the second wave of the statement, and again Paolo is one of the best player of this team. So thanks all the members of the scientific chairs of the scientific committee, and particularly thank to Carlo and to Kobe and all the people who are now connected. I think that you will enjoy the Paolo presentation, and you will have the possibility to ask for questions to Paolo. So I think again it will be a great success. Please, Kobe.
Thank you so much, Giovanni. Just before we start, and for the reason that you are all over the world are here with us this evening, is the presentation of the statement. I will just tell you that we are not able to see you or to hear you. If you want to ask a question, you have the ability on the Q&A to ask questions that we will try to answer, mainly Paolo, at the end of his presentation. I hope that the time will give us the opportunity. You can chat with us and with each other through the chat button, where you can send messages to each other if you wish. And of course, if there is something needed to say, you can raise a hand and say it as well. We will deliver the answers at the end of the presentation. Don't forget that we have also questions to you. And Paolo prepared a few poll questions. You will be able to vote. You will see it during the presentation. So vote, please, as soon as possible on those questions that will get an overview of the issues. And please remember that if you would like to see the slides later, that will be possible, that in some moment the presentation is recorded and will be available on the ESSM website. So Paolo, I will stop sharing my screen and you will share yours, and we will be able to enjoy your presentation.
Okay. So I will start. So first of all, I would like to thank the ESSM for giving me the opportunity to talk you about our statements on shockwave therapy. I would like to thank Carlo, Kobe, and Giovanni for the wonderful introduction, and also to thank my committee, because without them, this work will never be possible. So let's start with the topic of tonight, which is shockwave in sexual medicine. It has been a hot topic for about 10 years probably, and now is still something that is very discussed. So let's start with the definition of shockwave. As you may know, a shockwave is a longitudinal acoustic wave consisting of a short pulse characterized by a peak positive acoustic pressure, and this wave can propagate through water or soft tissue just as ultrasound does, and have a minimal tissue absorption and no thermal effect. But what are the applications of shockwaves in sexual medicine? Mainly there are three applications, which is erectile dysfunction, Peyronie disease, and chronic prostatitis. I would like now to give you the first poll question, if probably Kobe can show you the question.
You can all vote right now.
Okay, so
you see the results?
Yeah, I see the end of the results. So I see that most of you choose the first option, so vasculogenic erectile dysfunction, which is correct, and we will see why. The second option, chronic asymptomatic Peyronie disease, is actually not correct, and you will see why in a while. The same for bacterial prostatitis, and of course, all of the above, which I see 40% of you have chosen, is not the correct answer, but you will see it now. So we can go back to our presentation. Okay. So shockwaves have been introduced in clinical practice with some background coming from basic science. These are just theories that have some evidence, but this evidence is not definitive yet. But we know from animal studies and from in vitro studies, the shock waves on penile tissue can induce the release of vasculogenic growth factor, can also induce the release of nitric oxide. They can activate resident stem cells at the level of the endothelial cells, and they can also induce the recruitment of progenitor cells, and they have probably also an effect in terms of one cell activation, in terms of neuroregeneration. The same for Peyronie disease. There are theories coming from basic science showing that probably shockwave may exert a direct mechanical effect in remodeling the penile plaque, but they can also increase local blood circulation and enhance inflammation with macrophage activity resulting in plaque lysis. And in the context of chronic prostatitis, we have evidence showing that shock waves can induce an hyperstimulation of nociceptor, interrupting the nerve impulses responsible for pain. They can also reduce the perineal muscle tone and increase the local blood flow, all resulting in reducing of pain. What the other guidelines of the main urological societies says about shock waves in sexual medicine. So about erectile dysfunction, you can see that the EAU, which was recently updated, stated that shockwave treatment can be suggested in patients with mild vasculogenic ED, even as an alternative first-line therapy in well-informed patients. The AUA actually still considered shockwave as investigational, and the society, the North American Society for Sexual Medicine, believes that there is not robust clinical trial data to support the efficacy of shockwaves. The same for Peyronie disease. The EAU recommend to offer this treatment to treat penile pain, but not to improve penile curvature and plaque size. And the AUA stated that should not be used for the reduction of penile curvature or plaque size, but may be offered to improve penile pain. Regarding prostatitis, there is just a recommendation from the EAU stating that this treatment could be effective in the short term. But what about ESSM? So we developed last year we developed these statements looking at the effect of shock waves in erectile dysfunction, Peyronie disease, and chronic prostatitis. And for each of these diseases, we try to provide statement on treatment efficacy, treatment protocol to use, clinical indications, and safety. Overall, of course, we applied the Oxford Center for Evidence-Based Medicine to give recommendations. So I will ask Kobe to show you the second poll questions that I have prepared for you.
And you can now vote.
Okay, so we have the final results. 84% of you choose the right answer, which is young men with mild to moderate ED. They are actually the best candidates for shockwave therapy, at least among all the options that you had in these poll questions, and you will see it shortly. So let's go back to the presentation. So regarding erectile dysfunction, at the time the statements were released, we had 10 randomized clinical trials plus 5 meta-analyses investigating the effect of shockwaves on erectile function. As you can see, most of these studies are actually sham-controlled trial, and they are not. They have few participants. They are not very big studies. And sorry, these are the risk of bias assessment regarding all the studies included. Actually, they are all mild to moderate risk of bias, except for 2 of these studies, which were high risk of bias, and so they were not considered when providing the statements. After the statements were released, so mainly in the last few months, 4 more trials and 3 more meta-analyses have been published, and you can see summarized here. We have 2 more sham-controlled trials and 2 trials comparing different protocols of treatment. So from this table, you can see a sum up of the results of all these trials that we have analyzed regarding erectile function outcomes in terms of IIF improvement and erection hardness scale improvement. To make it easier, I have put for you a red flag to the trials that shows that show an improvement, a significant improvement in both erectile function and erection hardness scale. A yellow flag for trial showing an improvement only for one of the outcome, and a blue flag for trial showing no significant improvement as compared to sham treatment. So as you can see, the evidence is quite ambiguous in terms of the results, because there are trials showing positive findings, but also some good trials showing negative findings and no difference as compared to sham therapy. These are the new trials that were released after the ESSM publication, statements publication. And in this case, in the 2 sham trial, the 2 sham controlled trials, there were positive findings in terms of erectile function change and EHS improvement. Also, when you look at the meta-analysis, actually all meta-analyses that have been published show a significant improvement in terms of IIF score after shockwave treatment as compared to control, to sham therapy. Mainly, as you can see, the mean difference in the IF score from baseline is ranging from about 2 points to 4 points. And I think this is very important to know, because this gives you an idea of what is the effect that should be expected with this kind of treatment. We have to say that all these meta-analyses have some pitfalls because they include very heterogeneous studies. Some of them, they include studies with patients treated also for Peyronie disease or chronic pelvic pain syndrome, and not only for vasculogenic erectile dysfunction. And there are some meta-analyses including also having also a double inclusions of the same trials, and thus overestimating the final outcome. Regarding penile hemodynamic, there are 3 sham-controlled trials showing changes in penile hemodynamic after shockwave treatments, and all of them show a significant improvement in penile blood flow as compared to controls. And indeed, this was also confirmed by a meta-analysis pooling data for hemodynamic changes and showing that peak systolic velocity did improve of about 4 points in patients treated with shockwave as compared to control. So getting down to our statements regarding the efficacy of this treatment on erectile dysfunction, for patients reported outcomes, current evidence is certainly promising, but is still controversial, and therefore a clear clinical recommendation of shockwave for erectile dysfunction cannot be made. Regarding penile hemodynamics, we say that shockwave significantly improves penile hemodynamic parameters. However, then if you look at follow-up for these studies, you can see that randomized trials have follow-up ranging from 1 month to 1 year. So we are lacking data for longer follow-up at the moment, at least for sham control randomized trials. And so our statements on the effect endurance is that current data suggest a variable effect of shockwave up to 12 months after treatment, but we need, of course, more data to assess the longer term effects. As you may know, there are several different treatment protocols that have been published for the treatment of erectile dysfunction with shockwave therapy. And first of all, you can have 2 main type of generator, a focus generator or a linear generator. Focus generator have mainly electrohydraulic or electromagnetic energy source. Linear device have mainly a piezoelectric energy source. As you can see summarized in this table, most of the trials have been published using a focused generator, but some trials have been published also with linear generator. And the most important thing is that there are no trials comparing the 2 types of generators, so we actually cannot at the moment recommend one over the other. Regarding the protocol, so first of all, number of shockwaves. How many shockwaves should we give to patients? Again, there are no convincing data regarding this type of parameter, but for example, in this meta-analysis, the author pulled the data according to different number of shockwaves delivered, and they showed that the patients receiving more than 1800 shockwaves were the one showing the best outcomes in terms of erectile function improvements. And this has been confined by other meta-analysis, but also, for example, have been not confined in a meta-analysis by Zhu et al. In this trial, once again, looking at the number of shockwaves that we can give to patients, the authors performed a very well designed study showing that patients receiving 18 sessions or more sessions as compared to the adults were the one who reached the minimal clinical important differences in terms of IEF score improvement in the majority of cases, which is 83% as compared to 62%, for example, for patients who received less sessions of treatment. What about energy flux density, which is the other parameter that you have to consider when you design your protocol? There is actually a novel randomized trials looking at different energy flux density. In these trials, 4 groups were compared with comparing different number of sessions, but also different energy from 0.005 to 0.09, 010. And as you can see, if you read the paper, actually in the end, there are no significant differences between the groups in terms of erectile function improvement, although the author stated that there was a trend over better results for patients receiving a treatment with the. So we just talked about statements on treatment protocol. Move on the clinical indication. Who is actually the right patients who should be submitted to shockwave therapy for erectile dysfunction? As you can see from these tables, mainly all randomized trials that have been published included patients with vasculogenic erectile dysfunction, either responder or non-responders to PDE5 inhibitors. So first of all, I think it is very important to perform a duplex ultrasound assessment and define vasculogenic ED patients before to submit them to this kind of treatment. And then, of course, you can perform an overall clinical assessment looking at age, comorbidities, previous use of other medical treatments, especially PDE5 inhibitors. And this is important because as you can see from the meta-analysis that have been published, for example, this one, it seems that the patients that have the larger effect in terms of erectile function improvement are the one with mild to moderate ED in terms of erectile function score. In this study, which is not a randomized trial, but is interesting, the authors showed also that younger patients and the one with less comorbidities were those who get the most from this kind of treatment. Once again, PDE5 non-responders can be also submitted to treatment. Of course, the goal for these patients is totally different, so they should not be counseled for a treatment that can guarantee unassisted erectile function recovery, but they can also get a benefit from this treatment because they can revert their condition from non-responder to responder to PDE5 inhibitors, as this trial showed where half of patients who were non-responders were able to achieve erection with PDE5 inhibitors at the end of shockwave treatment. So our statements on indication is that shockwave therapy should be suggested for patients with vasculogenic erectile dysfunction, and it shows encouraging results, although unambiguous evidence is lacking, and the pooled effect size is modest. This is something that should be always discussed with patients when suggesting shockwave therapy. Finally, safety. What about safety? Regarding safety, there is very convincing evidence because all randomized trials reported no no adverse events at all associated with this kind of treatment. So we can say that for sure shockwave is a safe and well-tolerated procedure without clinically significant adverse events. And this is a level 1 grade A evidence. So now we move to Peyronie disease, and I will ask Kobe to show you the last poll questions that I have prepared for you.
And you can now vote.
Okay, so these are the final results. So 64% of you choose reduced pain, although some of you choose curvature decrease, plaque shrinkage, and 28% all of the above. So this is probably also coming for your personal experience. I'm quite sure about that. But you will see now from my presentation that the evidence that is available to everyone is quite different, and that it is that this kind of treatment is useful in patients with Peyronie disease only to reduce pain. But let's go back to the presentation so that you can see what I am talking about. So at the time these statements were released, there were 4 randomized clinical trials and 1 meta-analysis testing the effect of shockwaves on Peyronie disease. Actually, there were 3 sham-controlled trials, the 1 trial comparing shockwave with tadalafil. As you can see, first of all, the characteristics of patients are very different among the trials, because some of them are including patients with acute phase Peyronie disease, some of them are including patients with stable disease, and some of them are included patients with pain, but no definitions regarding the phase of the disease. This again is the risk of bias assessment, which is mild to moderate for all studies once again. And this is these are the results summarized in this table regarding the efficacy in terms of plaque and curvature reduction. Once again, I put for you here a red flag for this the outcomes, which means pain, plaque size, and curvature degrees. All the other studies did not show any significant difference in terms of plaque size changes and curvature changes as compared to sham treatment. On the other side, we had in almost all trials except one, very convincing data regarding the reducing of pain, which was, as you can see from this picture here, lower after treatment as compared to patients receiving sham therapy. So our statements on treatment efficacy for patients with Peyronie disease is that for curvature, there are no data supporting the use of shockwave therapy. For plaque size, there are no data supporting the use of shockwave therapy to reduce or even stabilize the plaque. But for pain, it could be an option to reduce pain, although patients should be carefully counseled that no effect should be expected on curvature and plaque size. So the indication is that shockwave can be proposed as an option to reduce pain in patients with either acute or stable Peyronie disease. Regarding the treatment protocol, once again, we have different protocols that have been applied in all studies, but mainly they all included 4 to 6 sessions with either focused or linear generator. So even in this case, we cannot provide any recommendation regarding a specific treatment protocol. And then again, for safety, no severe adverse events have been reported. There are only 2 studies reporting bruising on the treatment sites or some local small petechial bleeding, but nothing really severe. And so we can say also that also for Peyronie disease, shockwave is a well-tolerated procedure without severe adverse events. So the last chapters of our statements were dedicated to chronic prostatitis, which is the last indication for this kind of treatment in sexual medicine. At the time the statements were released, there were 5 randomized clinical trials plus that have been published, and one more trials have been published after the release of the statements, which is the last one in this table. First of all, as you can see, all patients were patients with abacterial prostatitis, and as you can see, the study duration, it ranges from 12 weeks up to 36 weeks maximum. And this is important because, as you can see from the results, we have actually good data showing in terms of symptoms improvement using a validated questionnaire for pain and for specific prostatitis symptoms, but also the IPSS score, so urinary symptom score. And this is true actually for all sham control trials that have been published. Although we do not have any evidence regarding objective measures of improvement, and I'm talking about mainly uroflowmetry parameters, for example. But what is important to know, and you can see it very well from this picture from one of those trials, is that this improvement is clear in the very first weeks after treatment, but after that, it seems the patients go back to the baseline situation. So we have probably an effect in the short term, but probably this treatment need to be repeated in the long term to achieve durable results. And this has been also highlighted in a recent meta-analysis pooling data from all this trial, where the authors concluded that at 24 weeks after treatment, there was no significant difference between control group and treatment group in terms of symptoms improvement. So the statements on treatment efficacy are that Shockwave can be considered as an option to relieve pain in patients with chronic prostatitis, although they should not be considered the primary treatment, of course, for this kind of condition. For the effect endurance, we can have a clinical benefit in terms of symptom improvement up to 12 weeks, but longer term maintenance has not been proven. And there are no specific recommendations regarding the effect of shockwaves in terms of non-symptomatic outcomes. Also for chronic prostatitis, of course, we have no specific recommendation for treatment protocol because there are no data comparing different treatment protocols. Most of the studies were applying a protocol of one session per week for 4 weeks, but again, there are no studies comparing treatment protocols. So the indication is patients with non-inflammatory chronic prostatitis, and also in this case there are no data showing any severe adverse events after treatment. So this should be considered a safe treatment. So in conclusions, to summarize what we have found from our systematic research and from our analysis of the literature, which is summarized in our statements, is that Shockwave is for sure a safe and well-tolerated procedure, but its efficacy for the treatment of erectile dysfunction is promising, although still doubtful, and patients should be carefully counseled regarding the treatment expectation. Patients reporting pain associated with Peyronie disease may benefit from Shockwave, although no effect is expected on disease progression. And Shockwave is not the primary treatment for chronic prostatitis, but may be considered as an option to relieve pain. And this is the end of my presentation. I think I will give now the floor to Kobe.
Thank you so much, Paolo, for summarizing the statement in a nice and efficient way, and in a way that everyone can remember the main recommendation from our society concerning Shockwave. There are 4 questions by the audience, and please, I will read it to you, and if you can give comments on them. The first question was that the person who asked the question had many doubts regarding the shame control studies. When you do a shockwave treatment, both the patients and the operator can feel the shocks. How can these studies be really double-blinded? What is your opinion about it?
So some of the studies, at least in the description of the methodology, they stated that they use a sham probe, which was not delivering the energy, although providing a sound which was resembling the sound of a normal probe. Of course, you cannot be sure about that. We have to say probably that the concept of blinding is always something that can be tricky for all the trials. So of course it is something that we can discuss, but even with blinding or not blinding, the evidence is still conflicting. So this is the main thing that we have to acknowledge.
Another question concerning the studies. What is the reason of having such few number of good quality studies, to your opinion, Paolo?
So one of the main reasons, which was always, it was mainly sponsored, I would say, by Dr. Azikristo at all the last ESSM meetings, is that there are no money to conduct very high quality randomized trials, because most of the time it is very difficult to find funds for this kind of trials, as all people working in andrology, in sexual medicine, you know that it is not like working with oncology or other kind of diseases. So most of the time the reason is the lack of funding. The other reason is that probably at the beginning people they were just trying to provide novel data, and they will try to perform small studies rather than looking at performing multi-center trials. Yeah.
Totally in agreement. There are two questions about the role of shockwave in after radical prostatectomy, and if it is an option, and what is the role?
Yeah, so I did not include this part on the slides because otherwise it was too long, but I think it is a very important point to discuss. Probably need a separate presentation. So that the theory from basic science, as I show you, is that this kind of treatment could be, and again I underline this theory, could be effective both in improving the blood flow, but also nerve regeneration. So it seems that patients after radical prostatectomy who have a damage to both the vessels and the nerves should be the best candidate for this treatment. Actually, to date, we have one single arm cohort study showing some promising results after radical prostatectomy, but patients were treated 1 year after the surgery, which is probably too far. Then we have a trial conducted after cystectomy, showing that the shockwaves could, used as a penile rehabilitation, could reach the same results as PDE5 inhibitors, but no more. And then there is recently the first randomized trial applying shockwave as a penile rehabilitation after radical prostatectomy. Actually this was a negative trial showing no effect. For sure we need much more data to answer this question.
There is a question about the patient in acute phase Peyronie disease without ED. Do you think it's better to offer a shockwave alone or in combination with tadalafil daily?
So I think that I mean, both tadalafil and shockwaves have data regarding their efficacy in relieving pain in patients with Peyronie disease. Even if we need to stick to the evidence, there are level 1 evidence for shockwaves because we have randomized trials, but there are no randomized trials on tadalafil for relieving pain in patients with Peyronie disease. So probably, of course, you can do it. If this is something that can be dangerous, I don't think so. It is something that can be discussed to the patients, but we cannot answer to the question if it is better or not, because we do not have data on that.
From studies, we don't have any results. I know that there are some people with clinical experience, including me, who are using this combination, and you notice that that there is faster results concerning the reduce of pain, and in case of not extreme curvature, some improvement as well. And I know from 4 people who use it in clinical setting, but there is no publication on that. Another question regarding discomfort and pain during treatment for ED. The person said that some patient he knows have sharp pain during the treatment. What is your opinion on that?
So I have personally performed, of course, shockwaves for patients with erectile dysfunction. It's true that some patients have some discomfort. I don't know if they have pain, probably mainly discomfort, at least what I saw in my practice. This was never reported in the randomized trials. I still believe it is something, it is a very safe and well-tolerated therapy. Of course, some patients can have discomfort, but this is something that it is not, is still not dangerous for the patient.
Yeah, my experience is whenever you aim it to the bone and not really on the tissue, that could give a sharp pain. You can try it with your finger, then you can see it. But I see that Giovanni would also like to say something about it. Giovanni?
No, just I totally agree with Paolo regarding the pain. Probably it's not a real pain. Probably it's just a sensation of the patient, maybe a fear about the treatment. So I never seen pain or severe adverse event related to shockwave.
Totally agree. Thank you, Giovanni.
Same experience, Kobe, also from my side. No pain so far, really. Very, very safe.
Yeah, that is also my experience. Not aiming on the bone is very important. And I think on willing of the time, the last question, there are 2 questions concerning vasculogenic patient. First, what it really means mild to moderate, and what is approximately the success rate?
Okay, so mild to moderate, it's referred to something, of course, I mean, you can refer to this kind of definition only if you use validated questionnaire. Otherwise, it is very difficult to say mild or moderate or severe erectile dysfunction. So when I said during presentation mild to moderate, I was referring to the IEF score going from 17 to 21, roughly. Regarding what was the second question? I don't remember. The rate of success, the success rate. So if you look at trials, mainly you can have a success rate in this kind of population ranging from 60 to 80 to over 80%. So even in this patient, it's not 100% of erectile function improvement. Then we can have a discussion regarding the fact that you consider success probably patients who gain 1 point in the erectile function score, but this is probably not clinically meaningful. I mean, you can say that you have an improvement in the IEF score, but we do not know if the patient really perceived this improvement.
One of the audience also showed us that it's very important to know which machine you use. and I see a lot of questions that I save about how many sessions and the duration. I write it, type the answers. It's very important to know which indication and in which machine you are using, because they have different protocols. Do you agree, Paolo?
I totally agree. There are so many protocols. I think that you should use the protocol that is suggested by the machine that for the machine that you are using. Even if I normally look also what are the protocols that have been used in randomized trials with that machine before to decide.
Okay. Again, Paolo, thank you so much for very efficient presentation, and that we learn a lot from it. We are very pleased with it. And
thank you, Kobe.
And again, for your audience, thank you so much for being with us this evening and listen to the great presentation of Paolo. I would like to stress that the presentation will be recorded and published on the ESSM website. When, how, and in which terms, I cannot tell you right now, but we will certainly advertise it on our website and our newsletters and in our social media. So keep follow us in all the events. Before we finalizing, I would like to remind you about our upcoming Congress, and remember that we have a support program to our members. If you have questions, if you need kind of emotional, psychological, or clinical support, certainly in this COVID period, don't hesitate and send us an email. You will find it on our website, and very interactive website with a lot of information. And as our president told you, we have there also a lot of videos and clinical information as well. And don't forget that the next webinar will be on the 27th of May about the assessment and hormonal management of adolescent transgender people. And after that, we will have about sexual desire discrepancy. On the 10th of June, hormonal contraception and female sexuality. On the 16th of June, on partner expectation, satisfaction, and about penile prosthesis by Daniel Osmanov and our president, Carlo Betocchi. On the 18th of June, the use of Kavanaugh's nerve injury model in post-radical prostatectomy ED by Fabio Castiglione is with us this evening. And on the 24th of June, energy-based devices for female genital urinary indication by Javier Romero and Leo Lowenstein. So stay tuned and be with us. And again, thank you so much for joining us for this webinar, and stay safe. Do your best to be safe and nice to your colleagues and friends and family. And we are looking forward for the moment that we will be able to join each other again and see each other very close in a normal situation. Thank you all for being with us.